Hello everyone, I'm Dr. Rohan Khandelwal, your MSN Surgery faculty, and I'll be discussing some important clinical questions for your mains exam. And congratulations to those who've cleared the preliminary exam, and all the best for your mains exam. Let's talk about certain important questions. The first one is, a patient who had undergone an abdominal cholecystectomy has a tube connected to the drainage bag. On the evening of the surgery at 10:30 p.m., 300 ml of bile was recorded from the collection bag, but by 6:30 a.m. in the morning, only 60 additional ml of bile was seen. What should the nurse consider in response to this observation? Now, please remember that in case the bile or any tube which you have in the body, in case the output suddenly drops, right, what can be the various scenarios which suggest that the output has suddenly dropped? That there might be a mechanical issue. So sudden decrease in output in any drain can be due to drain blockade, drain can get kinked, or there is removal of the drain. Of course, if there is removal of the drain, there will be soakage of the dressing as well, because the drain fluid might come out from the side of the drain. Right, so these three things we should keep in mind if we notice a sudden decrease in the output of the drain. So here the correct answer is going to be mechanical issue with the T-tube, means the T-tube is blocked or it is kinked. 24 hours after a below knee amputation, a patient uses the call system to tell the nurse that his dressing, a compression bandage, has fallen off. What is the first action the nurse should take? So once this compression bandage has been put, because we want to reduce the bleeding, right? We want to reduce the bleeding at that side. So if the compression bandage has fallen off, it is a very practical and a simple question that we have to reapply the compression bandage to make sure that bleeding does not occur at that place. You also know that any bleeding which occurs 4 to 24 hours after surgery, that is called reactionary hemorrhage, and any hemorrhage which occurs after 24 hours is called secondary hemorrhage, right? So in such a case, we want to prevent the reactionary hemorrhage, and that's why we are trying the compression bandage. Okay. A nurse is monitoring an adult patient admitted for an automobile accident. The patient has sutured laceration and a casted fractured leg. Initial vitals are BP is 120/72, pulse rate is 76, respiratory rate is 16. 1 hour later, the BP is 108/68, pulse rate is 90, and respiratory rate is 22. Right, so there has been a laceration. They've said that there is fracture after an accident, and what can we see here? That the BP is falling, pulse rate is increasing, and the respiratory rate is increasing. All these we know are signs of which shock? These are signs of hypovolemic shock. In hypovolemic shock, we know that the earliest sign is what? Correct. Earliest sign is increase in pulse rate or tachycardia, and then finally there is hypotension, which is noted as well. So this would be a patient of shock. Increased intracranial pressure, patient is going to have Cushing reflex. Now Cushing reflex, what we get in Cushing reflex is bradycardia. You're going to see bradycardia and hypertension and altered respiration. Those are the findings which we are going to see in Cushing reflex, which is seen in patients with raised intracranial pressure. Okay. Now match the following sutures with the type of their composition. We've discussed this so many times. We've discussed the chemical names of sutures, absorbable, non-absorbable sutures. So here the correct answer for vicryl, polydioxone, dexone, and monocryl, right? We have to match them with their chemical names, and the correct answer is C, right? So vicryl is, we know it is glycolide plus lactide. Polydioxone is polyester. Dexone is polyglycolic acid, and monocryl is glycolide plus caprolactone. So these are the chemical compositions which we should remember, right? So these are all, these three are absorbable sutures which we need to know about. One constant question which is asked in the exam is regarding tumor markers, right? Which of the following tumor markers is elevated in carcinoma breast? It is CA15-3, right? These tumor markers you all should remember because they're frequently asked. 15-3 is in breast, CA19-9 is in gallbladder and pancreas, CA125 you know is seen in ovarian cancer. Alpha fetoprotein, AFP is alpha fetoprotein, this is seen in liver and testicular tumors. CEA is raised in colorectal cancers. Medullary thyroid cancer, this has been asked, is calcitonin, and beta HCG, LDH and alpha fetoprotein can also be raised in testicular tumors. So these tumor markers you need to remember for your exam. They've been asked many times and you should remember them. A nurse is educating a patient before surgery about a device shown in the image. The nurse explains the primary purpose of this device. Now, as nurses, all of you know the purpose of this device. This device is put in the post-operative period or those patients who are at high risk of developing what? DVT. So this is a mechanical method of preventing deep venous thrombosis. These are pneumatic compression stockings, right? These are pneumatic compression stockings which are a mechanical method of preventing DVT. Now you know, if they ask you what is the best method of preventing DVT, the best method is pharmacological method. And pharmacological method, you know, the best method is low molecular weight heparin. That is the best method to prevent DVT, but this is one of the mechanical methods. A 40-year-old patient was taken up for exploratory laparotomy for acute intestinal obstruction. During the operation, the surgeon found a gangrenous segment of ileum of 50 centimeters. Anesthetist informed the surgeon that the blood pressure of the patient was dropping and the patient requires inotropic support. What should the surgeon do? So this is an unstable patient. Unstable patient, our aim is to finish the surgery quickly. Because if I keep on operating in an unstable patient, the patient will die. I will have no patient left only, right? So that is why whenever you have such unstable patients, you should finish the surgery quickly. And that procedure is known as damage control surgery, where we quickly wrap up the surgery to save the life of the patient. Then we optimize the patient and then we re-explore. That is called damage control surgery. A home health nurse is visiting a patient who underwent a right-sided mastectomy with lymph node removal. Patient is concerned about a swelling in her arm on the affected side. What intervention should the nurse discuss? So every time in your mains exam, there is either one question from breast self-examination or there is a question related to post-mastectomy lymphedema precautions. This is a guaranteed question which is always there. So you people should know both the things. Now here we know that there is a risk of lymphedema, the arm swelling up. So what all things we need to do? Application of ice alternating with warm moist packs? No. Avoidance of vaccines and injections? Yes. Elevating the arm? Yes, to reduce the swelling. Performing isometric exercises so that the swelling reduces? Yes. And the use of intermittent pneumatic compression sleeve is also correct. So 2, 3, 4, 5. That is answer D is the correct answer here. A middle-aged patient comes with dysphagia for liquid. Barium esophagogram is done. So first of all, you should know that this is a barium swallow, right? Barium swallow is for esophageal problems and we use the thickest paste of barium, right? Now here you can see that there is gradual tapering. This is known as bird's beak appearance, and one more hint which they've given is that there is dysphagia. Dysphagia we know is difficulty in swallowing, right? And this is more to liquids. So this is seen in achalasia cardia. In achalasia cardia, there is loss of ganglion cells and the lower part of the esophagus does not relax, right? In cancer, we get rat tail appearance or irregular margins, right, in cancer. And cancer, there is dysphagia to both solids and liquids, and there is prominent weight loss as well. 40-year-old chronic alcoholic comes with distended abdomen, hematemesis and fresh blood in stools. On examination, huge ascites and distended veins are seen. What is the most likely cause? So let's see the hints which they've given us. Chronic alcoholic, distended abdomen means the patient has ascites. Hematemesis means blood in vomitus and blood in stools, right? All these are seen in which condition? They are seen in portal hypertension, which can be seen in chronic alcoholics. And most likely cause of the bleeding would be varices, which are formed in portal hypertension. So these are dilated veins which can bleed. Okay. Erosion of the gastroduodenal artery is the cause of bleeding in a duodenal ulcer, right? But in a patient who is alcoholic, esophageal varices can cause bleeding. Common carcinoma of upper one-third. Upper one-third we know of esophagus is squamous epithelium. So squamous cell carcinoma is the most common there. Whereas lower part of the esophagus, so lower part of the esophagus, you will get adenocarcinoma. So lower one-third, we are going to get adenocarcinoma. A triage nurse received a 20-year-old male client following a laceration on the head. Upon assessment, respiratory rate is 20, strong pulses, and capillary refill time is less than 2 seconds. Client says he cannot move his leg. Which triage category will this patient fall in? Let's see your answers. Yes, so the correct answer here is yellow. Why yellow? Right, because this patient probably has a fracture, and all fractures are going to come under yellow category. Red category is emergent care, right? This is first priority. So this will include airway obstruction, tension pneumothorax, cardiac tamponade, all those conditions which can kill within 1 hour or which can kill quickly, all will come under red, and this will require first priority. Black are the dead bodies, right? Black are the dead bodies or the moribund patients whom you can't save. They have injuries which are so severe that we cannot save these patients. They are bound to die because, if we pay attention to them, we will miss out on a lot of other important or other salvageable cases. Yellow includes fractures, and green is walking wounded, means green is just small lacerations or bumps. So initially if you read here, there's just a laceration, but you have to read this line where he says he cannot move his leg, which suggests that there is a fracture. Stress ulcers which are seen in burns are known as curling ulcers. Cushing ulcers are seen in head injury. Cushing ulcers are stress ulcers seen in head injury, right? You can have rodent ulcer. Rodent ulcer is basal cell carcinoma, which is locally invasive, but it does not metastasize. That is basal cell carcinoma, commonly seen over the face. What is the best investigation for Zenker's diverticulum? Now, Zenker's diverticulum is an outpouching, right? We know Zenker's diverticulum is an outpouching of the esophagus. Now, I told you for esophagus, best would be barium swallow. For esophageal problems, we are doing barium swallow. What is EUS? EUS is endoscopic ultrasound. True about direct inguinal hernias, right? So direct inguinal hernias, you know that this is the anterior superior iliac spine. This is the pubic tubercle, right? You have your deep ring here, fine. You have your deep ring here, and you have the superficial ring here, okay? Now, you know there is a Hasselbalch's triangle. There is a Hasselbalch's triangle which is there, and this Hasselbalch's triangle Fine. This Hasselbalch's triangle is bounded by the inferior epigastric vessels, outer border of the rectus, and the inguinal ligament. So direct hernia is going to come out through the Hasselbalch's, means it is coming out medial. This is lateral, this is medial. It comes medial to the inferior epigastric vessels. This is the correct answer about direct inguinal hernias, and this triangle is known as the Hasselbalch's triangle. This has also been asked in the exam. Chronic rejection and renal transplantation usually occurs after, right? So what are the types of rejections which can occur? You can have hyperacute rejection. So hyperacute rejection in kidney occurs on table. As soon as you anastomose on table, this is due to preformed antibodies. Acute rejection can occur within a few months, and chronic rejection is now the most common rejection. This is type 4, and it occurs after 3 to 6 months. That is why more than 12 weeks will be the correct answer here. Kidney transplantation is a type of allograft. Allograft is when same species, so you take it from one human and give it to another human, that is an allograft. Isograft has been asked so many times in the exam. Isograft is between identical twins, correct? It is between identical twins. This has been asked many times in the exam. And xenograft is different species, means pig heart transplantation or pig heart valve transplantation, that is known as a xenograft. Commonest type of renal stone in case of UTI. Now this is a very tricky question. You have to read the question, otherwise you will go wrong in this. Look, overall most common is calcium oxalate. Overall most common is calcium oxalate, but here they are saying UTI. In case of alkaline urine, it is triple phosphate stones. In case of infection, it is triple phosphate stones. Overall most common is oxalate. So please read the question and then mark the answer. Cystine stones are very hard. They are very difficult to break. TURP, transurethral resection of prostate, was done in an old patient and he developed altered sensorium. What is the cause of this altered sensorium? This is known as dilutional hyponatremia or water intoxication. This is dilutional hyponatremia or water intoxication, which can be seen when TURP or hysteroscopy is being done for a long period of time. And one more thing which I want all of you to remember is that always gradual correction should be done in case of hyponatremia. Not more than 8 to 10 milliequivalents per liter per day, because if rapid correction is done, what can happen if rapid correction is done? If rapid correction is done, that can give rise to central pontine demyelinosis. So we don't do that. We have to be careful in these patients. True regarding wound dehiscence, right? If you suspect dehiscence, close with continuous suture of non-absorbable material. Dehiscence happens on second post-operative day. Management of wound dehiscence depends on degree of evisceration, and there will be a sudden gush of fluid just before dehiscence. This is going to happen when the sheath opens up, when there is burst abdomen. So which might not be the case in all wound dehiscence. This is wrong and this is wrong. So management depends on the degree of evisceration and the gangrenous bowel. You have to manage it accordingly. Which of the following is not a bariatric surgery? Now, what is bariatric surgery? Bariatric surgery, we all know, is weight loss surgery, right? Bariatric surgery is weight loss surgery, and this, when are we doing? When the body mass index is more than 40 kg per meter square, or BMI is more than 35 kg per meter square with obesity complications. With obesity complications, right? So that is when we do bariatric surgery. And this is bariatric. Roux-en-Y is bariatric. Duodenojejunectomy is not bariatric. And sleeve gastrectomy is the most commonly done bariatric surgery these days. Management of an open wound is seen 12 hours after injury. So if the wound is quite old, if 12 hours have happened, if you do straight away suturing, then there can be chances of infection. So we always first need to debride. Debride is remove the dead tissue, right? Remove the dead tissue and then we suture. So you might ask, sir, what is the cutoff? Right? Cutoff is 6 hours. So less than 6 hours you can straight away suture. More than 6 hours you have to then debride and suture. Okay. So please remember, 6 hours is the golden period for a wound. Modified shock index is calculated using, right? So shock index is heart rate by systolic blood pressure. That is shock index. Modified shock index is heart rate by mean arterial pressure, and this is a more sensitive value as compared to shock index, right? So these are used for monitoring hypovolemic shock, and modified shock index, which is heart rate by mean arterial pressure, is a more sensitive indicator than shock index. A nurse is performing a post-operative assessment on a patient who just returned from a hernia repair. Patient's blood pressure is 90/60 and apical pulse is 108. What should be the nurse's first reaction? We've discussed so many times. What does this patient have? Hypotension and there is tachycardia, right? There is hypotension, there is tachycardia, and hypotension and tachycardia are signs of hypovolemic or hemorrhagic shock. So what should be the first action? She's already documented the vital signs, right? So check the dressing for bleeding, because that would tell us if the bleeding, what is the bleeding source. Wounds that heal by dash intention are left open for several days to allow for edema and infection to subside. You know that wounds, if they are sutured, we call them primary intention. Secondary intention is when they are left open and they heal gradually, but the scar is bad. Tertiary intention is initially left open, then sutured after few days, right? Then they are sutured after few days. That is called healing by tertiary intention or delayed primary closure. This also you should know about. This is asked frequently in the exam. Which wound would be allowed to heal by secondary intention? So we discussed that just infected wounds or edematous wounds which will not hold sutures are the ones which are allowed to heal by secondary intention. Cleft lip repair, no. Infected hysterectomy incision. So they've given a hint. Infected incision, yes. There we have to leave it open so that it can heal gradually. All others we can suture. A 33-year-old male patient is involved in a motor vehicle accident as a pedestrian. He is brought to the casualty department in a cervical collar on a face mask. Initial observations are respiratory rate is 22, BP is 80/40, GCS is 7/15. You know Glasgow Coma Scale. What is the next step? You know that in trauma A, B, C, D is followed, right? A is for airway, B is for breathing, C is for circulation, D is for disability. And if the GCS is 8 or less than 8, that means the patient's airway is compromised. Patient is not breathing properly, right? Airway is not clean. So the first thing which we are going to do here is insert an endotracheal tube. A patient is demonstrating pulmonary edema, hypotension, delayed capillary refill. Nurse suspects patient is experiencing which type of shock. Now you know that this is the heart, this is right side, this is left side. Okay. Right side is going to pump blood into the lungs, and from the lungs blood is going into the left side of the heart. Okay. Now if there is failure of the left side of the heart, the blood will not be able to come here, so lungs will be full of fluid. That is why there is pulmonary edema. So this is a sign of cardiogenic shock, and in these patients the neck veins will also be distended. Okay. Obstructive is also a type of cardiogenic shock only, which can be seen in pulmonary embolism. Tamponade. Tamponade is when there is rapid accumulation of fluid or blood around the heart. So these were some clinical questions which I wanted to discuss with all of you before your mains exam. I wish you all the very best. You people have done all the hard work. It is just a matter of revising, reading the question, thinking about it, and then marking it properly. All the very best.